Okay, so formal apologies for the meeting, Anu.
Yes, I have Miranda Alcock, Sue Bell, Sylvia White, Soma Champanari, Arun Theagarajan, and potentially Anne Keen-Mayer.
Okay, all right, thank you. And we are quorate, are we not? Yes, we are. Okay, any declarations of interest in anything that's on the open agenda, please? No? Okay, good. In which case we'll move on to look at the minutes of the meeting we held on the 7th of December. That was a Teams meeting. I don't propose to go through it line by line, but I will take any points of accuracy that anybody has. No, not seeing anything. In which case, Anu gets the gold star for today. Very appropriate on International Women's Day. And we'll take those minutes then as accurate, and we'll adopt those minutes. Thank you. Good set of minutes, Anu. So, governor activities is normally covered by Shirley. If she's got voice problems, are you going to cover that, Michael?
Yes, oh, sorry, I'm muted. Yes, I am. Shirley's asked me to do so. And I just would ask you to receive the paper that is published on the agenda. And I just have a couple of things to add to that. As you see from the paper, the governors have been quite busy. But in addition to what our usual activities, we've had two things that have been quite significant. Firstly, Shirley had the initiative to organise an informal meeting of governors, just governors, so that we could share the information that we gleaned from things that only a limited number of governors can attend, like the board committee meetings, and also the visits that have been the conducted visits with members of the executive team around the hospital. And that meeting proved very, very useful indeed. And the sharing of experiences made it almost, say, basically come alive to the rest of the governors who attended, to hear from those that had actually been involved either in those committee meeting observations or hospital visits, how valuable they were. The other thing that I would very much like to thank you for, Andy, and your NED colleagues, was the away half day, which was immensely informative. We, as you, those that will attended will remember, we had quite a long session on membership, and I think Lily will be speaking a little more about that when it comes to presenting her committee report. But we also had a speed dating session with various non-executives, which were immensely informative and very, very, very welcome indeed. And I do hope that the opportunity to do a similar thing will be afforded in the future, because I think that those governors who attended found it very helpful, very informative, and were very grateful to the NEDs and indeed to you, Andy, as chairman, for the time that you afforded to give us a really close insight into the hospital's working. So thank you.
Thank you, and I just extend that to Tom Smerdon as well, who facilitated the membership session, who put a lot of effort into that.
Oh, well. Yes, indeed, yes.
Okay, so anybody got any questions for Michael on the meetings, the various meetings? You have been busy. That's very clear. A lot there, and just to say from my perspective, it's been really good seeing the governors at number one at the various committees, and I think people seem to really welcome that and have a good experience. And number two, obviously at the away day, and of course at the walkarounds as well. So I think we're getting back to where we were pre-COVID, which was, you know, the governors getting to know non-executives and executives better through actual personal face-to-face contact. So I think that's very, very positive. Okay, thank you, Michael.
Thank you.
So we now move on to Chris, the patient experience report.
Thank you, Andy. And in a similar way to Michael, you have the patient experience report in front of you, and I won't dally on it, but I would like to just highlight a couple of things. So, firstly, following on from the discussion you just had, I would point to all governors to the comments that Lily Evans made about how useful she had found taking part in a walk around, sorry. And encourage all of us where we have availability to volunteer when the invitations come round, because I think getting back into the hospital and getting actual face time with people is going to be really important in helping us progress our agenda going forward. We did look at the membership again. I refer you to the paper to look at the detail of that. And Andy, I don't suppose Shirley has spoken to you car parking charges yet. In fact, I think I might have put my hand up to take the short straw on having a discussion with you. Should a discussion be had with you? I know no one probably wants to have it with us, but should it be had with you, or is there someone else you would like to point me towards? Are you on mute, Andy?
I think we're happy. That should be executive and non-executive. So I think myself and Julie would be there, and we might have Simon along as well. But I think Julie, just take your view on that.
Yes, yeah, no, happy to have that conversation, Chris, and hopefully helpful to be able to explain the set of circumstances and obviously the financial pressures. And you're referring to the increase in charges and what we've done around that, and I suppose the communications and understanding what the particular issue from your perspective is. But more than happy to sit down and talk through that.
And very short, very quickly, it's in the paper, but the main issue is the difference in the price of the Runnymede car park, which is right next door to the hospital and the hospital car park. I think we've had lots of debates about car parking charges overall. I don't think we propose to reopen those debates. It's just a question about how you communicate and the differences. And then lastly, we're looking forward to return to our visits. We didn't have one this time for two reasons. One of a number of new people joining, but also because when we set up the agenda, there was going to be the maternity discussion on the same day. That didn't actually happen, but that's why we haven't had a visit to report. Andy, I can take questions, but I think to let you get on, I'll stop there.
Okay, thank you, Chris. Ellen?
So I just wanted to feed something back on patient experience. I had need to actually contact the hospital via ANU with a patient's relative who had been in A&E and complained about long waits and lack of facilities and drinking. You know, kind of being offered a snack or something. And I've had some wonderful resident feedback that I'd like you to feed back to A&E. On the basis of the complaint that I put through to the hospital, they did some work and they said it's such a difference it makes now. They've had squash and water and cups in all the areas offered to the patients who are having longer waits within A&E. And I just wanted to feed that back. It's always good to have positive feedback when you've done some work, isn't it? Often it's just negative feedback, but actually positive is so important.
Yeah, thank you. And certainly when I was going around A&E, I noticed when there's a volunteer in, it really helps because the volunteers have got the kind of bandwidth to make cups of tea and do stuff. Obviously, there is the drinking thing there, but nice to have some positive feedback. Thank you very much, Ellen. Okay, any other points for Chris before we let him go? Okay, thank you. In which case, Lily, on membership and community engagement?
Yes, well, like Chris, I'm not going. Is my camera on or off?
It's off now. Oh, yes, it's off at the moment.
It's off. It shows on here. Is it on now?
No.
It says turn camera on. Well, I've turned it on. I don't know what's happening. It
Don't
is
worry.
possible that I know what it is. My phone sometimes grabs the camera from the.
That's it. We've got you.
Yes, yes. I've just looked at the mobile phone and it's disappeared. So membership, we had a meeting and unfortunately it was not as well attended as usual. There were only 3 of us and 2 apologies plus Lucy and Anu. So I would encourage more governors to please join us because I think it's important that we have active members from different areas that the hospital covers. The main thing I think that I can pull from the minutes and from our conversations, which you have probably heard in the exchanges that we had in the away day, is that we are looking both to engage, not necessarily increase the number of members, but to actually engage the members in meaningful ways. And I think we are still trying to find the best way to do that. We are certainly, Tom is certainly very active and is planning ahead with the schools and in particular with the Bourne Academy, who have got quite a number of schools in our area to engage younger people. And as soon as you engage younger people, you will inevitably engage their parents and or the school staff. So I'm hoping that that is going to really bring some significant input. We also need to think more, how are we going to resurrect those sessions that we used to have with our members and medical staff on specific topics. And we should really look forward to doing something about that. But my immediate concern is that we have dropped the ball with our communications with Aspire. There has been nothing that happened since November, and we still haven't got the date for it coming out in March. We have asked for a regular, just simple one-page updates on a monthly basis that apparently the comms do on social media, but somehow members would feel shortchanged that they're members and they don't get anything. But if you are on social media and just follow the hospital on Instagram or on Facebook, you're going to be updated with the news releases that inevitably happen anyway. So we're not asking for anything specifically being written that you need some extra effort. Just think that we need to think what is the benefit of membership, and that is a closer connection with the hospital. At least knowing who is who, what's happening, good news, Eternal Gardens, great news, the specific things that we have got for our efforts in terms of the new kitchen and healthier food, electric charging for the bikes. These are all very good news. And if we don't let the members know, they're only going to hear the bad news. And that's not good for anyone. So please, whoever has got some influence, can you please tell them that we're not asking for anything out of the ordinary, just trying to make sure that we are all connected well.
Thank you. And I'm seeing that you did put some actions on the comms team that were with you there, Lily. Are you saying that?
What we did last time and nothing happened.
Okay, all right. So look, let's, I see Sal's got a hand up. Do you want to respond, Sal?
Thank you, Andy, and thank you, Lily. Yes, completely agree with all of those points. And for the benefit of everyone who took the time out to join the Governor's Away Day a couple of weeks ago, Anu and myself and Tom, and supported by the comms team, we've pulled together an action plan of all of the encompassing actions that came out of that day. It was really, really helpful discussion. And we're working through deliver, and it does absolutely encompass those regular comms and bulletins and a wider piece really around engaging with our members. Tom might want to add, but I certainly wanted to offer some assurance that we've taken that away. We heard that message loud and clear, and we're pulling together a programme of work to deliver on it.
Tom?
Yeah, thanks, Sala. Yeah, I mean, you've said it. I mean, we've got a good action plan now. We need to take that forward. I think it would be good to do that under the auspices of the Membership and Engagement Committee, if that's okay, Lily, with your guidance and leadership around that. But behind the scenes, Sal and I and others will work to make sure those actions are taken forward. We've just relaunched the Refresh strategy last week, I think. So there's been some recent comms around that, and we've been pushing membership as part of that whole comms and engagement piece as well. And then just to fill in the piece around the younger membership drive, we had a good conversation with the Bourne Academy last week, which has resulted in them offering to recommend around 15 to 20 of their pupils to take part in a roundtable discussion with us about a younger membership offer, which is really good. And as well as that, we're just polishing off a survey with the support of the Winston Churchill School in Woking that can then go out to a range of schools. We've already got some good schools links through Heather Bixley's offices, so we're getting quite a lot of momentum behind the younger memberships work as well. So thank you for your support on that, and thanks to those who were able to attend the discussion last week or the week before.
Thank you, Tom. Andy, did I see your hand go up?
Yeah. I was just you've cleared some of the questions I had there, but the point I was also going to make is at the away day, because Lily had to leave, I did offer my services to Lucy as a sounding board. You know, the offer is there just as a governor if you want a voice to bounce things off, and obviously I'd communicate that with the rest of the membership team. So the offer is still open to you all.
Thank you. Yeah, if you make sure that's minuted, Annie. Thank you. Thanks, Andy. That's great. Are you finished, Lily?
Yes, just wanted to say thank you to Tom, because certainly he has been extremely helpful and active. And I think as long as we have the whole team working, I'm sure there will be a real difference. We are just not there, that's all.
Okay, thanks, Lily. That's very helpful. Any other questions for Lily on the membership side? Just to reinforce, you know, particularly for those who went at the away day, you know, the two roles of the governors, you know, one role is holding the board to account through the non-executive directors, but the other and very important one is representing the membership. So this is a really important committee. So do flock to join it. We do need good people on that side. And yes, the executive and the governance team can support it. But it is really important that governors supported properly, engage with the membership. Richard.
Yeah, just one for Tom and co, really. My daughter is head of year at for the A-level set at the local comprehensive, and she's crying out for some access to the NHS, as in, you know, recruitment evenings, and indeed I mentioned membership to her for the students, and she was very interested. So I just wondered if there just a generic email with a link through to the membership site would suffice in the short term to get some interest at all schools without having to go into too much detail, and you know, just to get something done quickly, get the ball rolling.
Tom, it's always better if it's targeted to somebody, isn't it, rather than general?
Yeah, I think what we probably, I mean, Anu might want to come in here, but clearly, I mean, there is a direct email directly to Anu, and it's very straightforward to sign up as a member on the website. So that is straightforward. I suppose what we are maybe doing less well is if somebody's got a very specific interest in a specific part of what we do, how we direct that through to the right person who can make that happen. We can look at that, I think, and add that to the action plan. And probably haven't got time to go into the detail now, but maybe offline, Richard, we could have a quick chat about specifically what we can do for your daughter and how to link her in.
Yeah, because she, as I say, she's been speaking to colleagues in other schools, and they're all interested in careers evenings, school visits to the hospital, You know,
Good.
some work experience, mentors. The list is endless.
Well, it'd be great to have a conversation with her. If we can pick that up, thanks.
Yeah, I think Louise will be very interested in that as well when she joins.
Okay.
Thanks, Richard. We'll pick that action up, Anu, please. Okay, in which case we'll move on according to the timetable, and we're now going to move on to the assurance report, which Julie is going to present.
Thanks very much, Andy. So my assurance report, I will take it as read as previous reports, but there are particular areas that I just thought it would be helpful perhaps to pull out and share with you. Broadly speaking, this paper has 3 parts to it. So it should really represent at a glance, at a single reading, an accessible report that describes all the work that we're doing. And I'm sure that you can see it is a very busy time, and that point's been made in relation to other activities, but it is a very busy time. So an update in terms of all the activities that are ongoing. Then there's a short finance update around month 10 finance performance, and then an update on the BAF, the Board Assurance Framework, in relation to the core hospital risks. So as I say, I'll take the paper as read, just a few areas, starting with the CQC inspection as one of the first things that I wanted to share with you. And we did have a meeting previously where I shared with you the fact that we'd had the inspection, the targeted maternity inspection, and there were a number of areas that had been identified where the CQC felt that we could absolutely improve, and we received that 29A warning notice. I wanted to update you to say that we are actively working on the improvements against the key areas that were identified, particularly around triage and how we're supporting our patients through our caesarean section pathway, and addressing some of the workforce vacancy issues in maternity. So a lot of this work was already ongoing, but we've really used this as an opportunity to reboot the work that we need to do. And as I said at the top of the meeting, Andrea is actually currently on our weekly meeting with the local team at the ICB and NHS England in terms of our recovery plan around maternity. So we're going through a process with the CQC in terms of checking the draft report for factual accuracy, and that's a bit of a sort of to and fro process, a very formal process, as you would appreciate. But I wanted to absolutely reassure you that we aren't waiting for that final report to land, which should happen in the next couple of weeks. We are acting on the things that we need to do to address the environment, the workforce, and some of those pathway changes that we needed to make. In fact, Simon and I have just come back from a walkabout around triage, and we've seen all the changes that they've made to increase the space, because that was one of the issues that the team identified. So lots of work that's ongoing around that and improvements being made. Some good news that's in the paper as well, that we've appointed our new director of midwifery, and she joins us in April. So that's very exciting. She will be able to hit the ground running and support the existing maternity leadership team. And we know that particular areas of concern that the CQC raised around maternity relating to estates and facilities, capital build and workforce, that we really need to have some system solutions to address those issues. So I'm pleased to say that through my SRO role with the local midwifery neonatal service, that we've got our first system transformation meeting to look at the maternity and neonatal services across Surrey Heartlands, and that happens on the 12th of April. So we're making good progress around that. Other areas I just wanted to pull out: industrial action. I know that you'll all be very concerned about the upcoming junior doctor industrial action for next week. So the item in this particular paper reflects all the work that we've delivered to date in response to the various aspects of industrial action. So ambulance strikes and train strikes, and we didn't have nursing strikes locally because our nursing cohort didn't meet the threshold, but obviously we've provided mutual aid for surrounding trusts. But really just to say, and I'm sure James, when he talks about the performance report, we have very comprehensive plans in place for next week for the 3 days, and we have agreed harmonised levels of pay for our consultants to support them as they work down into those junior doctor vacancies, and lots of senior nurses leading in. And James has put together with Claire O'Brien, our lead for emergency planning and resilience and response, a very comprehensive response plan. And we will take that forward, supported by Surrey Heartlands and also Place colleagues, because clearly these the industrial action is across the whole of the system. James, you've just popped up on my screen. Did you want to say anything about that now, or you'll cover it later?
I could cover it in my. I think you've done, great summary there, and I can add any detail in my performance section.
Brilliant, thank you. Moving on then, just a brief update. Clearly, we're in this planning cycle, looking forward to 23-24, and we're working with colleagues across the organisation and across Surrey Heartlands in terms of how we put our response together for meeting the core operational and productivity requirements and ensuring that that's in line with the NHS long-term plan, and ensuring that we're working with all our aspects together. So we triangulate the workforce and the activity and the finances all together. And that's really important to us, and it is really challenging. And as we move into next year, when we look at elective recovery and moving back to payment by results, PBR, that will bring additional challenges as we focus on collaboration at the same time. So moving on, main effort, you will know that this is our successful programme to support patients through the emergency care pathway who do not require care within a hospital setting, and how we support those through ambulatory pathways. We have seen a real benefit this winter, and we have been able to support safe and timely discharge of this patient cohort, supported by the work that we've done at North West Surrey Alliance to create that capacity in the community. And we have been able to pull back from our escalation beds, which has been really good for our staff, great for patients, and also has helped our finances in this last quarter of the year. The Surrey Heartlands Elective Centre, SHEC, that's what we call it now. I won't steal Kathy's thunder because she's on this call and she's an expert in this area. I just wanted to give a quick shout out to the Sectra PACS Go Live. So this is our patient archiving communication system for radiology. I think that we all know that some of our go lives when we launched Cerner were a little bit rocky, and Sectra is a really great example where the implementation has gone really, really well. And it's not just here, it's across the imaging network. So it's across Surrey Heartlands and Sussex and Frimley as well. And again, I was up in radiology with Don and Richard yesterday as part of our planned walkabout, and heard from the radiologist how successful and how amazing that new system is, and that supports home remote working as well. So really exciting. And perhaps the last thing in terms of the narrative part of my report, the Patricia Hewitt review. So Patricia Hewitt is the chair of Norfolk and Waveney Integrated Care System. She's been commissioned by the Secretary of State for Health and Social Care to undertake a review of the statutory responsibilities of the new integrated care systems. And I'm on a working group and have been able to feed back in terms of our sort of reflections and ways of working, and how we're working through that new relationship with the integrated care system. So we are being able to influence that report, and colleagues and executives and also the ICB have responded in terms of the work that Patricia is taking forward. So we look forward to see the outcome of that, and that will really hopefully help us support the development of how we continue to work with our integrated care system partners, particularly in relation to provider collaboration when we think about how we deliver our acute care services. So I'm going to move on to the finance section very briefly, and Simon can mop anything up that I do slightly incorrectly or I don't cover. So in terms of the month 10 position, we have put our our concerted efforts into getting back to our forecast deficit position. So we're slightly behind in terms of our cost improvement programme, but we are holding true to our forecast deficit position. We said that the year-end outturn position would be at the 12.1 million. So that is a deficit position, but it was a planned deficit position. We did have a little bit of slippage earlier on in the year, and everyone's really pulled in terms of additional effort to reduce down our workforce spend by using our main effort initiatives to close down those escalation beds, and then we can pull back on our agency and our bank and our locum spend. So that is really great work. If we can achieve the 12.1, we are forecasting that we will achieve the 12.1. There's still more work to do, but as we go into 23-24, which will be equally, if not more challenging on the finances, what we've learned in terms of how we can make these savings and still deliver great clinical services has been really, really insightful and has taught us a lot, and it'll be really important to how we go into next year. In terms of the other key items around finances, cash balances remain in a good position, and the capital spend that's slightly behind plan, but it's all being managed under Simon's watchful eye, and he's nodding at me. Simon, is there anything that you'd like to add? We can't hear you, Simon.
Sorry about that. You can hear me now. No, I think you've covered it. I mean, just to give a bit more assurance, we kind of held that variance in months 8 and 9, and we clawed a bit back in month 10. So that should give governors a bit more assurance that we can hit the year end 12.1. I believe we can. There's obviously only 3 weeks to go. So obviously there's relatively few issues that could knock us off track now, I guess, from where we're at with such little time to go. So I think it bodes well.
Good. Thank you, Simon. And then the last part of the report relates to the board assurance framework. So colleagues will know that these are the key 17 risks that are subdivided throughout our sub-board committees that are pertinent to those areas. So the risks around quality are reviewed by quality of care and modern healthcare, financial and performance risks, and so forth. They've had a really comprehensive review this month, as always, by the chairs and the non-executive directors and the executives. There has been no significant change, no change to the scoring of the risks, but in light of the increasing financial challenges and also some of the quality challenges that we've seen most recently with maternity and CQC, the narrative description around the risks has been absolutely interrogated and changes made to those. And the KPIs that relate to the specific risks remain under scrutiny and are updated just to ensure that they remain relevant to the specific risk. So thank you, Andy. I'll hold it there and happy to take any questions. Thank you.
Thanks, Julie. Malcolm.
Thanks, Andy. Julie, thanks very much for that feedback. There's really only one thing that I'd like to ask, and it doesn't really come out in the assurance report. And that is that last time that you were speaking to us about the maternity wing, it came across that the senior leadership team were surprised that the report was as bad as what it was. Now, for me, I'm not too fussed about the maternity department as such. I'm more worried about the whole trust, because if you're surprised, then we need to make absolutely sure that there aren't any other surprises in other departments. So really what I would like to see is, as you work through the maternity exceptions report and also other exception reports which have come up, that you are actually thinking, does that, how would I relate that to the trust as a whole? And where do I need to just check to give myself the comfort that I haven't missed this in other departments? Okay, because I think this is really the key. We need to be assured that the whole trust is working smoothly. We don't want surprises suddenly come out next time we have another report. Okay, I think this is too important, and we need to use what is going on in the maternity wing as a way to validate that it's not happening across the whole trust.
Malcolm, if that was a non-executive question, I would say it's a very good question. As a governor question, it's the wrong question. The right question is to ask the non-executives, of which probably I'm the chair, to say, how are you assuring yourselves in the light of the maternity report that there are no other areas of the trust where there could be surprises? Because governors are not non-executives, but they are there to hold the non-executives to account, and that is our job. And let me answer some of those for you before I do for Julie. So first of all, I would say the surprises in the maternity report were limited. So there was no surprises around maternity staffing. There was no surprises around the estates. There were some surprises around the clinical side, particularly around triage. So there, and probably surprises the wrong word, that we were blindsided by that. So what did the non-executives, for a start, do about that? The non-executives were very clear that they wanted to make sure that there were no other areas in the trust, particularly around, as triage is effectively maternity's A&E, are there any other areas of triage that there might be issues? So with Sal's good help, we've refocused all the walkarounds on the triage areas, so that all the triage areas, Sal, I think I'm right in saying now, have been visited by the normal exec, non-exec, governors in some cases, areas, to make sure of that. And certainly, as far as maternity goes, we have been looking at the responses, and in particular the trio of people that have been looking at the responses of myself, Jane Dale as the head of the quality committee, and Aaron as the maternity NED, have been looking at all the responses the executives are putting back to the CQC on factual accuracy, etc., and looking obviously at the plan to how to fix that. So just to put your for your rephrased question, just to put your mind at ease that the non-executives are on this, and rightly, in my view, have ensured themselves that there are in other triage areas, which was the one thing that we were all kind of worried about, that there were no others. So I've probably said enough at that point, and now I'll let Julie say something.
Thanks, Andy, and thanks, Malcolm, for your question. Yes, so just building on what Andy said, the particular issues around triage, that risk was sitting on the maternity risk register, the divisional risk register. So what we've done as a result of that, and with Marcine's help with her expertise in risk, is we have undertaken a deep dive of all the risk registers. And that has been a sort of challenge process with Sal and Abby as our governance leads, with the information that Marcine has fed back, having reviewed every single risk that's on the divisional risk register across the 6 divisions, with myself and Andrea and David as sort of clinical operational challenge in the room. And as a result of that, some of the risks that were sitting on the divisional risk registers have been escalated onto the corporate risk registers. Lots of them have been de-escalated as well. Some of them were quite old, some of them needed to be updated. We've also taken it as an opportunity to ensure that all the leadership teams undertake risk management training as a mandatory action, so that we all have improved our skills around the management of risk. So that will now be a regular yearly occurrence to assure ourselves that things can't sit and languish on divisional risk registers, and anything that needs to be escalated onto a corporate risk register will come now to the executives on a weekly basis. So Malcolm, we are really trying to use this as a learning opportunity in terms of, clearly, there were a set of factors, relationships, communications, all of those things. At the end of the day, how can we put what came about in maternity into good use so that we can really assure ourselves and give you assurance that we are assured that our areas are safe and that we are doing the work to address the issues because we know about them. Myself and Andrea and David had a really good, honest conversation with the maternity leadership team last week, and we've pretty much landed, Malcolm, that with the volume of work and scrutiny that is around maternity at the moment, with all the various reports, you'll have heard of Ockenden, you'll have heard of Kirkup, and now we've got CQC, and there is a lot that the team need to do. It probably isn't business as usual within that maternity leadership team. So as part of the recovery, we're giving some wraparound enhanced support to that team to give them a bit of a framework to get back to business as usual. And when we've received the final CQC report, we will absolutely use that with executives alongside the maternity leadership team to share with the rest of the divisions and the rest of the leadership team, because you're quite right, Malcolm, in 6 months' time, the emergency department could be having a review. And how can we assure ourselves? And we have done a lot of work around the risk, as I've said, and looking at the other triage areas. But at the end of the day, this is our leadership team across the divisions that are delivering these services. So how can we make sure that they've got the resources, they understand what they need to do, they've got the freedom to act, and we're really clear about their responsibilities, and how can we support them in that? So it is disappointing, and we are really disappointed and distressed by what was found. We are cracking on with those improvements, but we are absolutely using it as an opportunity to improve across the whole of the organisation, not just maternity.
If I can come back, Andy, just on that. Firstly, Julie, thanks very much. Also, Andy, for your reframed question. I'm really pleased to hear that you're applying this across the whole of the trust. And that for me is really the issue. It's a trust-wide problem. It's not just a maternity problem. And it's great to see the senior leadership team have acknowledged that and are doing something about it. So I have to say, great stuff to everybody. Congratulations to everyone. Keep up the good work. The solution, or what the word I'm trying to look is the proof will be in the pudding when we have the next exception report, where we don't want surprises there. We want to know in that next exception report that we are expecting what comes up is because we know it's going to come up, not because we don't know it's going to come up. That's where I want to be. Okay. Thanks very much.
Thank you. Michael.
Oh, thank you, Andy. I just wanted to ask Julie in reference to 2.2 in her report about enhanced executive meetings. I'm very pleased to see that you're having executive consultant meetings. And I wondered, Julie, if that can, in a sense, have the side benefit of becoming consultant meetings to sort of facilitate even better cohesive working between departments to achieve more seamless patient outcomes. There do seem to be some little, let's say, gaps in communication occasionally. I wondered if that initiative can bringing lead consultants from different departments together can lead to better interdepartmental working.
Yes, thank you, Michael. Yes, you're spot on. Yes, absolutely. And that's a real priority for us. So the enhanced executive means that once a month we have the divisional directors, which in the main are medics. We have one pharmacist who is obviously clinical, but we have the clinical leadership alongside the executive leadership, so that we have a clinically led organisation. But also there is an opportunity for those divisional directors, which head up each of the 6 divisions, to have a good opportunity to talk and discuss and solve things between themselves. So you're absolutely right. We don't expect one divisional leadership team to sort of come up and expect the executive to broker or negotiate on their behalf. We want those divisional directors, those divisions working together. So say, for instance, we've got a challenge at the moment around paediatric emergency department, and that requires maternity health and paediatric division working in collaboration with the urgent and emergency care division. And it's about those two leadership teams coming together and absolutely resolving them. And David and I and Russ hosted an away day, well, an away afternoon for the divisional directors, just to do the very thing that you are talking about, to give them time to develop their professional leadership relationships, how they negotiate, how they influence, how they persuade, and how they come to the table with differing opinions, but actually they resolve things together. And that is absolutely the work that we need to do. And we had another away day last week for all the leadership teams, so the triumvirate and the executive, which was a really good, solid and slightly exhausting, but a really good way to develop those professional leadership relationships so people can work really efficiently together and resolve things and have good conversations without coming sort of up through the executive all the time. So yeah, you're spot on with that, Michael. Thank you.
Edwin?
Hi. No, I was just looking at the risks 2.2, 2.3, 2.4, and slightly worried about, this kind of high risk appetite. So can somebody talk me through why this was marked as high risk appetite?
Thank you, Edwin. I'm just looking. Are those the modern healthcare ones?
Yes, well, healthcare, and there's one or two digital, yeah.
Okay. High risk appetite. Well, I can make a start. I don't know if Simon or Sal wants to come in. I mean, I think this is probably in relation to the position that we find ourselves in terms of the challenges around operational delivery and financial delivery and our ability to continue to operate within that framework.
Yeah, obviously, yeah. Just wanted to learn a bit more because it is quite serious when organization says they're willing to accept quite kind of high level of uncertainty and in these important areas. So I was just trying to find out a bit more about what is behind that decision.
Simon, do you want to come in?
Our overall risk appetite has all the dimensions that are put on there. What it's essentially saying is we're less tolerable of risk around legislative or quality impacts. Finance, we're prepared to take a bit more risk to make sure we deliver the other objectives. So it's just a tool which tries to express and help individuals make difficult decisions across multiple kind of areas there. I mean, ultimately, clearly, you can't run deficits forever, and your risk appetite may evolve as if we get ourselves into that situation, etc. But it's a tool to aid decision making in a very fluid and kind of sensible way that delivers our overall objectives. I hope that's helpful, Edwin. I'm happy. It's a great big. I mean, Marcine's the expert on it. It's a subject that we could go on about for hours in terms of how we got to that particular matrix and those decisions. But safe to say it was a very thorough and well argued position that we ended up with.
So, for example, on quality, we would have a very low risk appetite. On digital, we would have a much higher risk appetite because sometimes you've got to try things and innovate, etc. And sometimes they'll work and sometimes they don't. And from the very top of government, it's kind of agile. And if you're going to fail fast, but try things out. So in some cases, that's the point. I know, John, you've got your hand up, John.
Yeah, and I think it's a good point that Edwin makes, and it is something, obviously, I think that Simon said that we have quite heavily at Modern Healthcare Committee, specifically in terms of those risks which relate to the modern healthcare objectives. Unfortunately, it is a situation of the position that we find ourselves in around the financial framework that we're faced with. And I think, as Andy's just alluded to there, I think we are getting to a situation, obviously, where we need to look at innovation and transformation in terms of how we might be able to sweat the assets that the trust has better. Hence why we want to forge ahead with things like the Surrey Elective Centre, hence why we want to get into things like robotics, etc. I think it's just an acceptance that there may be, financial risks, as Julie's already explained. The trust has got a very good financial track record, and we do have healthy cash balances at the moment. But if we look ahead to, where budgeting is and things at the moment, there's huge risks around that in terms of how do we, get sustainable operations. And I think that's what this risk appetite reflects.
Yeah. I'm just going to ask Marcin if she wants to add anything on the sort of generality of risk appetite.
No, I think my colleagues got it right, and I think they've learned well. So no,
Yeah.
I'm very happy with it. It's all about risk decision making and tolerance. Thank you.
Okay, just wanted to give you that opportunity, Marcin. Okay, thank you, Edwin. Any other questions for Julie on her bit before we hand over to James? Anne.
Yeah, just from my own understanding, if you don't mind, and sorry for my ignorance, but I'm assuming that also risk areas are very correlated. So if you have a higher risk in technology, that could potentially have an impact on quality. Am I correct, or am I not understanding this correctly?
They're all linked, Anne. So
Yeah.
one of the reasons we have the Audit and Risk Committee is each committee looks at the risks that it owns, the strategic risk, but then the Audit and Risk Committee takes a view across the piece on behalf of the board to make sure that exactly what you said, that there isn't something that, hiding in the correlation. And then that comes to board, and the board obviously looks at the whole board assurance framework as well. So yeah, we don't treat them in isolation. The committee looks at its own risks, but there is a method of making sure that the risks as a whole make sense.
Okay, yeah, thank you. Thanks.
Ellen.
Hi, thank you. I'd just like a little bit of a steer, actually. So as the appointed governor for Woking Borough Council, I have to write an update report every year of the activities of what we've been discussing, which has to be in by the 10th. But I'm just wondering what on earth I write about CQC, because it's not common knowledge, but no. I don't know what to write. I just need a kind of slight steer on the wording, I think, really.
Let me have a go at that, and then Julie can correct me. So I would say that there has been a visit to by the CQC to the maternity unit. That currently we have received a draft report and have commented on it for factual accuracy, and we are now awaiting their final report. So I think unless the report comes out before then, I think that's all you should say at this point.
Okay, thank you. I just wanted to get a double check before I write it.
Yeah, and obviously those councillors who represent the other councils as well might want to take note of that if you've got a similar process. Okay, thanks, Ellen. Okay, in which case we will now move on to James. The floor is yours.
Good afternoon, everyone. Can you hear me okay?
You're a little bit faint, James.
How about now?
Yeah, better.
Good. Okay. Good afternoon, everybody. So, as it's very topical, I was just going to say a few things about, as Julie introduced, a few things about the industrial action that we've got coming up next week. So it is. We've spent quite a lot. Well, we spent a lot of time on this over the last 2 weeks. It's really dominated what me and the operational and clinical teams have been focusing on. But we do have a very robust set of plans. Each division has worked up their plans at a specialty level, supported by me and David and other execs and the wider team. What we're doing at our heart is we are moving people from some of the elective services into urgent care services and areas that we don't want to stop working. And we're running those services 24 hours a day for the 3 days The vast majority are consultant-led. We have some junior staff that aren't involved in the action for various reasons. They're not the right grade or type of person, or they're all consultant-led outside of that. We will still be running all cancer services and urgent care services and our very long waiters. So in a moment, when I come on to report about our longest waiting challenge, those patients will continue to receive their care through this period as well. We're also working with partners across Surrey Heartland. So social services are working with, for example, we have our Home First team, which is a core component of our urgent care facility to help get patients home on the day. That's supported by social services, and they're running that for an extra 2 hours a day for us during the period. So we have lots of support from partners around us as well. Is there anyone got any immediate questions on that before I move on? I just want to provide a little highlight on where we are. We're providing an update to the organisation tomorrow. So we've been meeting daily around this to come up with our plans. We've got a big brief to the wider organisation tomorrow, but we've also got a lot of things around. Not only have we got consultant services through the period, but we've got a whole range of management support, including executive support on site from 7 in the morning till midnight each of the 3 days.
Marcy?
James, one question that's come up that's been raised is, will we do any kind of public communications like we did before, which is don't come, just to send some of the pressure off, or what is our plans communications with our communities? Thank you.
Yeah, so we're very much linked in with the ICS comms and NHS England comms. So at the moment, whilst we have got a bit of our own comms out, we are very much pushing and waiting for the ICS line on it. There are still meetings today. So the NHS Chief Executive today was meeting the Prime Minister, and I think they are still waiting until they put their comms out for the outcome of those sort of meetings. But we are not waiting for any of that. We are all ready to go, just to provide assurance. Okay, thank you. I'll go on to the performance report. So I'm going to put out some vignettes around some services. Now, this was December, so I can update a little bit on some of the performance since then. And I'm going to hold on some of the urgent care stuff because David Fluck and I are doing a presentation next on the agenda in a deep dive into ED. So I'll cover well, between us, we'll cover the performance challenges and opportunities in that presentation. So I wasn't going to draw too much on urgent care in this section, so we're doing it in detail in the next section. In terms of elective care, the key challenge for us, the single target that the government has set by the end of March, so the end of this month, is to eliminate patients waiting or eliminate waits of longer than 78 weeks by the end of this month. So you can see when we did the paper, at that point we had around 80 patients that were at risk of breaching the standard. Now, that was that point in time. It was part of our trajectory. We were on track to where we wanted to be. As we sit here today, we have 11 patients now that will be treated. We've got 2 patients that we need to date, but we've got 11 patients in total that we need to see by the end of the month, 9 of which are dated, 2 of which we're still working on. They're 2 gynecology patients. So in terms of the one standard that the government has set the NHS, in terms of elective waiting times, which is a 78-week standard, we are well on track to achieve that, just with 2 patients to date in gynae, which we are working on daily. So that should provide some assurance on the elective side. As you read the paper, you see December was a very busy month for us in the hospital, and we had a few things going on, one of which was still stabilising from our Surrey Safe Care launch earlier in the year. We have got explanation in the paper of what we were doing about that at the time and what we're continuing to do, certainly around the quality of the data that we use to track all our patients, all our elective patients through the system. We've also got a programme we're working on very vigorously called Waiting Well, and that's where we're looking at how we keep patients safe whilst there are longer waiting times. Now, we're one of the organisations that had some of the shortest waiting times in the country. So this is a bit of a new endeavour for us. We haven't really had to flex those muscles before around how do we keep patients safe on long waits because we didn't have them. But you read in the paper what we're doing around making sure that when we do have longer waiting times than we had, certainly shorter than a lot of other places, but they're longer than what we had, what we're doing to keep patients safe in that world. And as I've explained, the national standard right now is 78 weeks by the end of this month. That's a long way away from the 18 weeks that we were before COVID. We'll just move on to diagnostics. You can see actually I'm really pleased with our picture. So although we had a tick up in December in our diagnostic waiting times, the key challenge that I've been reporting to you through the various meetings for the last at least 18 months, if not before we went into COVID, was endoscopy. And as you can see, and as you've seen in the report, when we went into Cerner, we gave ourselves a further challenge in endoscopy. It was quite difficult there due to the build issues of the new program. However, you see in the report that we've come down there. We ticked up a bit in December. That's absolutely fine. We do that every December due to patient choice, pushing appointments past Christmas, and due to consultant availability. But the recovery in waiting times is really quite strong there. So we're 83.8% in December, which is a good position for us. And actually, we're the same in January, pretty much. So that's a strong position to report. I think the other strong position was normally during the winter, and David and I will explain a little bit more about this, we end up escalating our beds into various areas of the hospital. We didn't do that this winter, so some of the areas that we might escalate into, such as the urology centre that affect our diagnostic performance, we didn't do that this winter, and that was really helpful in terms of recovering some of our waiting time positions for diagnostics. And finally, in terms of cancer, you'll see in the paper that we've had some challenge there. Now, Julian and I have been reporting to the board that we would look to, we knew that we were going to get some recovery in performance during Q4 and after Christmas. Now, this was the peak of our challenge. We knew that we were going to get a lot of challenge here. Cerner definitely gave us challenge. There's no doubt about it. We had downtime. We weren't able to book as fast and swiftly as we wanted to. We had challenge in breast, and we also had a significant increase in referrals during the autumn. So particularly dermatology, colorectal and gynae, where we saw 40 to 60% increase in referrals in that month, at the end of the autumn, which is what we're experiencing now coming through. However, our performance has improved. So what you can't see from this report is in January, we're compliant for 4 out of the 8 cancer standards, which is the faster diagnostic standard, the TWR standard, the breast symptomatic, and the 31-day standard. And the 62-day standard has continued to improve as we predicted it would, or projected it would. So once we've got the first part of the pathway, the TWR, we're now at we're now over that, but in January reported we were 94.4%. So we're getting patients seen quickly at the start of the cancer pathways, and now we will get improvement through the rest of the journey. On the 62-day standard, which is one of our key metrics, it is the key metric for getting treatment in cancer. December here we were 78.3, and we've got improvements to make, and we know that will get better as we go forward. That was all I was going to pull out of the performance report, and we're going to do obviously urgent care in a bit of detail in a moment. So any questions, Chair?
Thanks, James. So any questions on that? We're going to come back to urgent and emergency care to have a bit of detail around that. So any other questions for James? Edwin?
Oh, hi. I just wanted to ask James about the workforce. I mean, you mentioned that some of the key areas, colorectal, dermatology, and gynae. So how are we doing with workforce? Are there gaps in workforce that affect some of these figures?
Yeah, the big challenge that we've had, Edwin, is definitely dermatology workforce, and that has been a challenge for us. It's a challenge nationally. We had a visit by the National GERFT team, and they actually felt that we were faring pretty well. compared to sort of the national picture. It is hard to recruit some of these areas, and dermatology is definitely one. The people training is not coming, you know, the training numbers are lower. The people coming out is quite a part-time profession. People are, you know, part-time positions. So that's definitely been a challenge that we've had in dermatology. However, in a recent set of interviews or a whole piece of recruitment, we recruited 4 consultants to our dermatology team. I think all have now started, and that has definitely made a really big impact for us. Along with other pathway improvements, and that is a really big, important factor in turning around our dermatology performance, which we've done, which has enabled us to hit the TWR standard overall. That's the 2-week rule standard. So yeah, workforce has been a challenge, certainly in areas like dermatology. In colorectal, not so much, and in gynecology, there are things that we're doing in-house to map our workforce accurately to the level of demand that we've got and the level of activity we need to work at. But that's an in-house issue. I think the one that was more about more of a national challenge was dermatology, but we are very lucky here. We've recovered that position with our workforce.
Yeah, no, thanks, James. And I suppose it's the is this kind of post-pandemic world as well, where people are now coming forward more, yeah. Because of the pandemic.
Yeah, that's right.
Okay, Lily.
Thank you.
I don't know whether this is for James or for the NED, who is responsible for performance, but really I'm just looking to find what assurance do you have that you will be able to get on top of, because cancer has been a long-standing, not exactly always meeting the various standards, and you yourself have said that some of those standards have actually gone from 18 to 78 weeks, which really is a big slippage if you were sitting at 18 weeks 2 years ago. So I'm just looking to find out how can we reassure ourselves that we're on the right track, and that if we get surprised by things, this is not going to knock us off course again as badly as this.
Yeah, thanks, Lee. I think that's a really good question, and it's quite worrying, really, that the national standards are where they are, and the national picture is what it is. But we're working hard to recover that. So we are one of a few trusts who can provide a lot of confidence that we're going to hit the 78-week position. And we've already got very, very small numbers. So we're working hard on that. We've got some bigger developments going forward. So we're setting up the elective centre, and that will help us and the region in terms of elective waiting times across the country, across the county. And in terms of cancer, we can demonstrate in the report, actually, I did want to draw people to, thank you for raising the question, draw people to the appendix, page 21 in the report, where we look at the national comparators and our cancer position. And whilst our cancer performance in December, definitely in December, was not where we want it to be, across all of the key indices, which is the 2-week rule for the wait for first consultation, and the 62-day standard for treatment, and the 28-day diagnostic, we are significantly above the national standards on all of them. And what do we do to provide assurance and make sure there are no surprises? So my director of performance, Julian, who is here, known to you, him and I there's an extremely extensive set of meetings and infrastructure in the organisation that meet specifically around cancer, and we have people whose job it is in each division to track cancer patients through the system. And there's a whole infrastructure in the organisation to support that. And there's a whole infrastructure, it's far, far bigger because of the size of it, to support the elective waits with, there are somewhere, we tried to calculate once, Lee, somewhere about 400 or 500 hours a week in the organisation go into tracking and maintaining elective pathways. So there's a lot of infrastructure in the organisation to ensure there are no surprises. And we work very hard to make sure that these things are in the direction we want them to be.
Yeah, and I think, Martine.
Lily, just from the NED's perspective, that we go through this report at great detail, and two improvements to this report that we'd requested and James and Julian have done, which you now see, are the comparative benchmarks, both nationally and within our system, so we know where we stand. And the second one that we like, and we've asked James and Julian to add, is trajectories, so that we get that assurance that they've got a plan on how to improve. And it is something, and James will know that we definitely challenge him on and hold him to account. So those are two improvements that we get, so we can triangulate data in order to understand where we fit in the context within the system. Thanks.
I would also add that it's scrutinized two ways, the performance report. Poor James gets it from all angles. He gets it from Modern Healthcare, and I see John's got his hand up, and Modern Healthcare is about the standard and where are we going and how are we improving the standard. And then, of course, the Quality Committee, led by Jane, looks at it from an impact on long waiters, for example, and the impact on the quality of care. So from a non-executive point of view, Lily, that's both those are scrutinised, and I've got John and Jane with their hands up. So John.
Lily, as Martin's already said, that these are debated quite extensively at Modern Healthcare, and certainly in terms of the AAA reporting, that you'd be aware that we've actually introduced. There's certainly the alerts have been raised at board level, and obviously the question that Edwin raised around workforce. Well, we have been working hard to actually get consultants and specialists on board in order to make this better. So it does get a good degree of attention actually in terms of the work of the committee and in terms of obviously the discussions that we have with the executive team, looking at the actions in specific terms.
Thanks, John. Jane.
Thank you, Lily. Just I think you have observed a Quality of Care Committee, but just to say that the key focus of the committee when they receive this report is to understand what it actually means for our patients, and to understand and be assured that there are processes in place to triage patients, to make sure that those that are long waiters, those that have got appointments, have been clinically checked. And that is something that we are provided with assurance at each meeting with James and his team, where they describe the actions that they take with regard to those that have fallen out with the targets, particularly those that need urgent treatment, and the clinical triage processes, particularly for the cancer patients that are undertaken, because it's obviously very key that individuals that are caught in this, that we have a mechanism by which we can safety net them.
Thanks, Jane. Right, I think we'd better move on. I'm looking at time because obviously we need to give time to this next piece as well, and we've got quite a full agenda. So, James, I think you and David are going to do this next piece.
Yes, that's right. So I'm just going to share my screen, if I can, if you just bear with me for a second. I just wanted to try and share it in a particular way. Okay, can you see my screen?
Yes, James, can see it.
Yeah, can you see me at all?
Yeah, sadly, yes.
Okay,
it's very impressive, James.
You know. Okay, so thank you, Chair. So David and I are just going to spend a bit of time talking about ED, and particularly I'm going to lead off with a piece that describes the work. There was some report by the BBC, and I'm going to explain the data that sits within that. I'm going to explain what the challenges are in ED and what we're doing about them, and the key things that we've done so far. And then David is going to take us through a piece which is our main effort, which you will have all heard described a number of times, including in this meeting. So if I kick off. Okay. So on this slide, what we're trying to show is the types of data that we have. Now I'm going to try and keep this really simple, so please bear with me. We are an acute hospital. We are here. So our type what so when we report our performance in our performance reports, I always give you two types of performance. And in the report today, you'll have seen that we have the NHSI performance, which is our A&E performance, and the local two walk-in centres, one at Ashford and one at Woking. And that's our type 1 performance that we report to NHSI and is recognised by NHSI. And that, well, we call that all types. So that's the higher figure. In January, we're at 97%. Sorry, so for our type 1, which is just St Peter's Hospital, we're at 56.9. Our all types, which includes the two walk-in centres, is the 72.4 that's in the report. Now, when the BBC presented the data earlier in the year, earlier in the month, they produced our figures. So our figures, Ashton and St Peters, we don't have any. We don't have the walk-in centres at Ashton and Woking, so they excluded that from our figures. But other organisations do. They do have walk-in centres in their patch. They do have big UTCs. So we were not being compared with. We were not being compared in the right way whatsoever. The right figures are the ones that I provide in the performance report that Julian and I share with the board and with you guys. Now, if I move to the next slide and show you what that means, we have in our performance report, we always include this data. This data shows how we compare both in the region and nationally for both types of A&E performance that we present. So in terms of our all types, which is us and the two local walk-in centres, when we were in January, we were 17th out of 28 providers, and we were 20th when we just looked at our own A&E performance. And when you look at the national performance, out of 112 providers, we were 55th or 58th. So we were absolutely in the middle of the pack in terms of the performance of A&E in the NHS in England. So I just really wanted to make that clear. That is with the performance that we report is correct, and the performance that we provide to you in our reports and provide to the board does show where we appear in the national rankings and what that's made of. The two performances, one is our own A&E with our UTC, and the second one, which we say is all types, is our A&E and our UTC, and the two walk-in centres in our patch at Ashford and Woking hospitals. And that's what we provide every month in this report. So when we look at this report, this shows how we compare. The previous one showed how we compare in the region in South England and in the whole NHS. This report shows how our all types performance compares to the other hospitals in our patch, the Royal Surrey and Sash. And you can see that, and the England average. So we are the blue line, the light blue line running across the top, and the England average performance is the purple line, the one that's running along us. Now you can see pretty much all the way through the period on the graph, we're running above that, and now we've just dipped to mirror the national performance. And you can see the other two trusts. It's interesting to see actually in April was when we launched Cerner, which was when Royal Surrey, the pale green line here, had challenge, but they've begun to recover in January, more so than we have, and Sash have had a number of problems and they've begun to recover as well. So you can see this is our all types performance and where we compare. So the point I wanted to get across here is how the figures are made up. So our type 1 and our all types, and how we compare both in south of England nationally and with our two local trusts in the patch. Is there any questions at this stage? No? Okay, then I'll carry on. So in terms of December, I just wanted to show that we've been having a really busy time. Now I'm obviously including a little bit of update from my performance report at the same time here. December was a really busy month for us, and you can see in this graph, and this is one that we've just pulled out of the performance report that we include all of the time, that actually before we went into COVID, we were looking at about 300 attendances a day. During November, it was significantly higher, and you can see in December there were 405. Now that's the highest number of attendances that we've had in any one month in the history of Ashford and St Peters hospitals in the 25 years that we've been a combined trust with Ashford and St Peters sites. So we have never had the level of attendances that we had in December. So what that just paints the picture of, and you can see that it's getting busy, or it's getting busier, and it's now very busy. In fact, this week we've been at similar numbers. We have 400 attendances on Monday again. So in the context of what we're describing a lot of pressure, more pressure and more attendances than we had pre-COVID. And in December, we also had the issues of Strep A. Pediatrics were 100% above their normal level of attendances, so they had double the amount of attendances. One of the points that comes out in the report, but only goes up to December, so I wanted to include January here, is I've been called to 2 national meetings of all the chief operating officers in the country in London. And the key element, one was in October, and then one was in January, the second one. And what the key point they wanted to get across to all hospitals in England was, we know there's challenge in A&E performance. Nationally, there's all sorts of different drivers for that. David and I will talk about that in a while. But what they wanted all trust to focus on was not holding ambulances in hospitals. And you'll remember all of the news articles and all the headlines about how many ambulances were stacked in hospitals. The real ask to everybody on those events and asked nationally was, you must release ambulances, you cannot hold them. And you can see here our picture. So although we had, so the top graph shows how many ambulances were at St. Peter's hospitals for 60 minutes or more waiting to hand over a patient to us. And you can see in December, when we had the really extreme levels of attendances that we had some challenge. However, in January, we only had 8 ambulances that were held. In February, and we haven't published the figures yet, and they're completely hot off the press, we had 0. That's something that we haven't achieved for 2 years, and we've never achieved in a winter. So the actions that we're taking, both to improve ambulance handovers and support other providers generally around us, i.e. CCAM, so that they can respond and be doing what they should be doing, which is being out and about. We've really done that. So whilst we've had some challenge, there are some things that we can be proud of, but we need to recognise that the team have done.
James, sorry to interrupt, but I can give you a maximum of 10 minutes from here.
Okay. So these are some of the things that we've been looking at. I will pull out a couple given the time that we've got. So we've already said that December was high. We know that paediatric performance has been a challenge. In December, we had to move the paediatrics location within the hospital to a bigger space. And that sort of took a lot of our time, and a lot of time that we wanted to be doing other performance improvement. On the non-admitted pathway, we've just outlined 3 challenges here that we're working on. One is around our same-day emergency care called SDEC, and one is now older persons assessment unit. We are working on keeping those open longer in the day. It's important that we get people to the right part of the organisation, and those parts of our process are open for the right hours of the day. So that's something we're working on. We know that when our ED teams at the front door put patients to the right areas, so same-day emergency care or to our urgent treatment centre, we know that our performance improves. And we know that we have issues of space that we're working on, what we can do in the immediate term within the constraints that we've got. We are working on and recognise the cultural change in terms of specialty input and output from urgent care, and we're working on supporting that with our divisional directors. We have a new divisional director in urgent care who started in the last 6 weeks. We're making some inroads into that piece. We're also looking at our clinical assessment unit and how we can ensure that we have flow into that unit out of A&E. And that's mainly around some of the work we're doing on the right side, which David's going to describe. The other thing that we're really trying to focus on is the time of our discharges. So when we have people in A&E needing a bed in the morning and our beds are becoming available in the main hospital in the afternoon, that is a problem. And that is what we need to be working on. So we have plans around that at the moment. Now, I covered that a lot faster than I wanted to, than I planned to, because of the time that we've got. We'll circulate these slides, so we'll give them to Anu. Because of the time today, we'll make sure that you have an opportunity to see these slides. But this is a bit of a timeline on what some of the key things that we've done in urgent care. And in the last 2 years, so from January 21 to now, it has been a big journey. We created the division of urgent care 2 years ago so that we focused at one management team solely on our urgent care services. And that was just 2 years ago. And in that 2 years, you can see some of the key things that we've done. So we've improved or increased the number of junior doctors. In August, we increased the number of ED nurses. One of the huge pieces of work which David led on across for us was the consultant staffing in ED. We've moved up, at this point, we moved up in September to a 10-person rota. We're now moving up to a 14-person rota. So for the purposes of time, I'm going to move on. But it's important to say these are some of the key things that we've been able to get in the last years, and we continue to hone, refine, and improve these actions that we're taking. I'm going to come on to that slide last. So at the moment, in the purposes of time, David, I'm going to come to you next.
Great, thank you. Do you want to go on to the next slide, James? Thank you. So I just wanted to briefly talk about, you've come off showing your slides now, James.
Are they back now?
Yeah, they're back now,
Yep.
Thanks. So just to identify, when things get really busy and challenging, you've got to work out where you put your effort, where we put our resource. And we've been fortunately working with Julie's chief of staff for a number of years. And during the pandemic, one of our main efforts at that time was to aim to stop anyone getting a transmissible infection if they came into hospital. And what we decided to do was to change that in the late January, February, and put our efforts on understanding what hospitals are for. And so the point here is that hospitals are really good places and excellent places when you need hospital care, but they can also be dangerous for people. So elderly patients, if they're brought into hospital, they can catch infections, they can fall, they can become confused, they can become deconditioned. So it's really important that we put our efforts in treating people and getting them home to their loved ones as quickly as possible. So that's the narrative that we need to do. If I go on to the next slide now, what does that mean? Well, can you put the next slide on, James?
Yeah. There we go.
So where we did is we concentrated on a number of things, and it's built up by our relationships with the system. So when patients are in a hospital and they shouldn't really be in hospital, it's not that they don't need support and care. What they don't need is to be in the dangerous environment of a hospital. They need to be at home where they feel safe and nurtured by the family. And so we set a program together to really understand what patients were in hospital that did not need to be here and they needed support outside, and worked really closely with our system. And actually, a lot of this work was led by Cherry Jordan. A lot of the medicine team were involved, and also adult social care from the community. So Linda played an enormous role in this. And the relationships in the system allowed us to understand what patients needed and get them back home. The other thing we realized is that actually you can't have all the resource in hospital that is not required and resource outside. So we needed to refurbish some of our wards, but also realign beds to what was needed in the community. And maybe that was more domiciliary care, maybe that was more rehabilitation, but we worked very closely with the system to work on that. And we also worked on, actually, we really need to assess people in the first place when they come to hospital. What do they require at the point of access to the hospital? And can we put that in place at the front door rather than bringing them into hospital and subject them to some risk? And we also worked on our urgent care pathways. And as you can see from our performance, and as James says, the emergency department is very busy, but the teams have worked incredibly hard on making our pathways safe and working on the navigation to try and navigate people through the emergency pathway. And there was a lot of other work that was put on in place for this. As James says, this work's been going on for a number of years now. James, can you send the next slide on? And I'll just briefly point to this. And it's simple things like the patient tracking list, which was developed in August 21. When you hear James talk, we've had tracking lists for cancer patients for numerous years, but actually tracking what people are waiting for in hospitals is not widely viewed. And we put a whole system together to look at that. We did test these hypotheses about criteria to admit and reason to reside. And then we fully launched the main effort in it's towards the end of January and the beginning of February. And if I go on and just say, well, what has that achieved then? I'll just show you the slides in the interest of time. Can you go on to the next slide, James? What you can see is that what's happened in the system through COVID and through the years is that the bed base in the system has grown and grown. This gives the number of patients who are in hospitals for more than 21 days. And as you can see on the left, that is an upward running curve. If you look in our system and you divide it into 3 organizations, what you can see is that that is mirrored in 2 of the main providers in this segment. But we're doing something very different in St. Peter's. We're reducing our bed base. We're reducing people being in a hospital for prolonged lengths of stay because we're understanding what they need and we're working very closely with the community to get them home. And that is a very unusual picture in the national picture. If I show you another slide, it shows it in a slightly different way. But you can see this is the summary of acute providers. You did tell me what this stood for, James.
It's one of our national reports. It's called a Summary Acute Provider Indicator Table.
Yeah, and as you can see, we're the green table on the left. And what that shows is that every length of stay in every patient, including our occupancy of beds, is going down. And that's not the situation we're seeing in the other providers. And so what that has allowed us to do is that has allowed us to reduce the bed base in the hospital and reinvest that in the community. And why you say is that important? Well, if we expand our bed base in the hospital, we need to stretch our substantive staff over a bigger area. We need to employ a huge amount of extra agency and bank to look after those patients, and we also give them harm. So John earlier on in this meeting mentioned the triple aim or the triple alert. Well, this is actually a really good example of the NHS triple aim, where you improve the patient experience because you're getting them home, you're improving the outcomes because you're causing less harm, and also you're making the system much more efficient in the process. And James, the next slide, if we can go on the next slide. So what are the next steps? Well, as James has already said, we're going to bring the 14 ED consultant rota. That's going to be ready and running in April. And what that does is that extends the hours that we have a senior clinician in our A&E department. During the pandemic, we built a whole extra building next to A&E, and we're working on that bottom floor as the same-day emergency care pathway, so we can actually get patients who come in ambulatory pathways and treat them safely and get them home in a great environment. And the way we're also doing work on that is to extend the hours of operation, because what we do see is that actually the strain on the emergency department is continuing for much longer into the early evening of patients coming up. And as James also says, we've seen an extraordinary rise in the attendances in paediatrics, and we need to work on that department. We've made some changes, and we're looking at those workflows, and we're going to change some of the pathways and some of the infrastructure to put around that. We're also looking at the readmission and the representation, so patients who come back in, or if they're brought in and we've electively brought them in, we need to remove them away from the emergency pathway. And also behind the emergency department, because the emergency department is only the front part of the pathway. Behind the emergency department, we're looking at the whole doctor staffing model that supports the clinical assessment unit, the short stay units, and the same day emergency care. And we're working very closely with the communities around virtual wards and community support. We've got a very close relationship with our place, and also developing more of the hot clinics that we have in our organisation. James, I think that's it actually, but we're
I think
happy to
we're
go
over
through.
time,
Yeah.
David, now as well, so that's helpful. James, is there anything last words you want to say?
No, I'm happy that we got across the key things that we.
I'm just
we
conscious
were
that Kathy's area is being squeezed here through no fault of anybody's. But so I'll take one or two questions, burning questions on that before we move on to Kathy. Anybody got any questions on that? I thought it was a really good explanation of what's been going on in there and just how complex it is. You've got to make sure you're counting apples and apples. And unfortunately, in the latest figures of the BBC, we're not counting apples and apples. Okay. But James and David, thank you ever so much for that. Oh, Michael's got one. Just got in, just squeaked in there, Michael. Well done.
Just a quick question on your apples, Andy. James, have you any idea how many attendances at the walk-in centres, the 2 walk-in centres, result in onward referral to emergency department at St Peter's?
Yeah, so from the 2 walk-in centres, if we take those to be Ashford and Woking, not very many. It's a very small amount,
right.
Fraction, single figures. Yeah.
Oh, thanks.
Yeah.
The urgent treatment centre obviously has a few more, doesn't it, James?
Yes, and it's integrated into our flows, in our urgent care flows on this site. That's a very different model, but yeah. The walk-in centres, yeah.
So in other words, the walk-in centres are doing a good job in keeping people out of A&E, I think is the summary.
That's what I was meaning, yes.
Yeah.
Thank you.
Okay, thank you, Michael. In which case, Kathy, you've been very patient. Would you like to take the floor?
Okay, thank you very much. Hello, everybody. My name is Kathy Parsons. I am the Programme Director for the new Surrey Heartlands Elective Centre, which we're hoping to create over at Ashford Hospital. Anu's just putting up there. I just did a brief presentation. Really, it's only just really for us to talk around. It's not full of data or anything. And so just slide 3, Anu. Yeah. Just to show you. So basically, during the COVID pandemic, you will all know that everything came to a standstill in relation to elective surgery. Obviously, emergency care carried on, but elective surgery stopped for the whole period, and patients stopped going to their GPs, and everything sort of came to a bit of a standstill. What happened during that time was that the patients who were waiting continued to wait. And the patients who were not waitlisted because they hadn't gone to their doctors sort of arrived at a later tranche when everything opened up again. The impact on that in the elective waits across the country is that the waits for surgical for surgery has increased substantially. As you can see, we've got here the NHS waiting list in England rose to about 6.5 million people. A large number of these had been waiting over 2 years. There's been an awful lot of work done, as James has already just been describing, about how to get those waits down, and everybody's sort of concentrated really hard on those really long waiters and done a great job to get right down to the sort of like the last lot working on at the moment with 78 weeks. But we are a long way from 18 weeks, which was the national requirement before COVID, as you all know. And so just to go on to the next slide, Anu. So basically, the government has worked on sort of a recovery programme for the country, and the idea is that they help us to bring this back into line. Patients are waiting a long time for their operations in pain. A lot of the conditions chronically deteriorate over time. So people waiting for a hip replacement coming up now, if they've been waiting a long time, the pain becomes worse, the mobility becomes less, they sleep less, they socialise less, all of their whole quality of life deteriorates. And those are the types of people that have been waiting a long time. So basically, the government has worked on this recovery plan, post-COVID recovery plan, and a large part of it is about how to fund doing things in a different way, so that if this ever happened again, anything like it, if we ever had to move all of our elective surgery to somewhere that wasn't impacted by emergency flow, or indeed something like COVID, that they're sort of an elective centre. So the idea is that they were funding us across the country for about 80 elective surgical hubs. The idea is that you separate emergency and elective flow. So emergency care, cancer care, trauma care can continue to come in as required, which is what it needs to do. But it doesn't impact on elective care because elective care is in a different site, a ring-fenced elective site with its own ring-fenced beds. And so we put forward, Surrey Heartlands put forward a bid to the national programme, and we've been successful in receiving some money and funds to build a sort of to build on to Ashford Hospital. Ashford has been an elective surgical centre for a long time now, and it does everything over there very efficiently and very effectively, and has done for a long while. The idea is really to sort of make the capacity there greater capacity, but also to help hospitals like the Royal Surrey and the Surrey and Sussex who don't have the facilities that we do. They don't have an Ashford hospital like we do. So it's a bit of mutual aid as well as helping our long waiters as well. Currently, the inequalities in care, so some patients will get in sooner than others depending on where they are in the area. As I say, luckily for Ashford St Peters, because we have Ashford, we're able to get our patients in, and the Royal Surrey and Sussex don't have it such a good flow. So it is all about helping everybody across the patch as well. So the next slide, Anu, please. The next one, sorry, I've done that. Okay, so basically this is sort of a bit of a visual of what happens on an elective centre, or what does an elective centre offer us. So basically you're able to sort of cohort one type or two types or three types of cases all in one place, which helps to sort of standardise the practice. Everybody gets the hang of how to do one thing and do it really well, or two things. It enables you to concentrate their best practice. You have specialised teams know what they're doing. You promote a culture of innovation. Everybody works well as a team in one place.
Yeah, could I have a cup of tea?
Your surgeons have your surgeons get used to having one sort of scrub team, and everybody sort of works well as one team in a sort of a ring-fenced way. And they don't get caught up in all the hustle and bustle of a great big huge emergency flow type of area where there's all sorts of other types of things going on. And so it helps our patients who are waiting a long time for their surgery. It is aimed at, these hubs are aimed to help with training of junior doctors, because obviously all the way through the pandemic, when elective surgery stopped, so did education for junior doctors, and that is a different type of backlog, but we now have to train the medical workforce for the future, and also make sure that it's never sort of halted in that way again. And so for Ashford Hospital, what this means is we will be building two new theatres, so two brand new theatres will go onto the site, and we will be increasing ophthalmology flow by creating an ophthalmology procedure suite. What that will do then is to free up a main theatre. So ultimately we'll have 3 main theatres to do larger surgery, and we'll have a new ophthalmology suite which will help us with our ophthalmology cataract type activity. Actually, the flow will increase to double, aiming to be able to provide 2 procedure areas next door to each other, so we'll be able to have 2 patients being treated at the same time. And so that will be what will go on at Ashford. That will be what will be added onto Ashford's physically, the physical build. And there's also some work on how we will increase the throughput through these theatres. So as well as the 8 and then 10 theatres that we will have, we will work on how they can be more productive, more efficient, because of the workforce and the promotion of that sort of culture and model over there. There's all sorts of national programmes to help us design and promote this type of work. And the Getting It Right First Time national team have done an awful lot of work on how to help the hubs develop, how to develop innovative hub workforce, and how to look at their theatre metrics for productivity and efficiency. So there's lots of ways that people can help us. So we're not alone in it. Actually there is an accreditation process for all of these national hubs. So we will go through an accreditation process, and hopefully we'll pass that. So we'll be an accredited, getting it right first time national surgical hub at the end of all of our hard work, hopefully. And so that's really what we're putting over there. If you go to the next slide, Anu, this is what it will. This is, I mean, it's a very basic ground floor diagram, but that's how it will slot into the current footfall. So that's the 2 new theatres on the ground floor, and for those of you that know the site, so that the front entrance is that sort of funny round thing there on the right, to the right of the green patch, and it runs along that long corridor. Is the long corridor that runs outside of the X-ray department. So basically, if you're stood at the X-ray department now and look out the window, it will be right in front of you, in front of the window. And it's attached to the day surgery unit to the left, which is where the patient flow. So the patients in and patients out will go via that day surgery unit. So that will enhance the day surgery unit, give some more recovery areas, which is the pink bits. So the pink bits are where all the patients will recover down there. So that's the 2 new ones, and obviously the other one I'm talking about exists already in the main theatres upstairs, and the new procedure suite we're hoping to develop in one of the empty areas in the hospital. We're just working on estates design for that at the moment. And that is my presentation. I've got no more pictures, but if anybody wanted to talk through that with me.
Thank you, Kathy. Andy.
Okay, yeah, thank you, Kathy. A couple of questions. Timescale of this is the first question.
So we're hoping to have those new theatres in sort of up and running by about January, February next year.
Right. Okay. And how is the elective centre being funded, as it's obviously being shared with other providers?
So as I said earlier on, the government designed this sort of how to tackle the COVID backlog national programme for how to help the country get itself back on its feet again, really, and help the patients that have been waiting such a long time. So it's national funding. We all had to write business cases, and ours was approved. So we have the money from the government.
But then the day-to-day running of it, who will pay? How does that get paid?
Well, I mean, obviously it's all very early days, but it will probably be the same as you run any other department. So it'll be sort of based on the money coming in from treating the patients. The usual sort of financial flows should exist once we get it all up and running.
Simon, I know you want to come in there.
Yeah, just to give a little more detail. I mean, it's essentially under the old PBR rules for elective and the elective recovery fund. So ultimately it's underwritten by the government. No doubt those systems will change over the next few years and evolve. They've changed every year for the last 3 years, but that's essentially the mechanism. There'll be a pooling arrangement, for work from elsewhere. So essentially it's a system asset. We'll share the benefits, the income, those sort of things with the rest of the system. And clearly we want a win-win, so everyone benefits out of this, the patients, the trusts. It should free up capacity elsewhere, for example, and particularly beds at Royal Surrey, which are very pressurised at the moment as well.
Okay, thank you both. Thank you, much appreciated.
Kathy, if I can ask one question, which is having the theatres split over 2 floors as opposed to all on 1 floor at the moment, is that going to create issues, or is that mitigated by being with the day surgery unit?
Yeah, so it's mitigated by the specialities that we'll put in different theatres. So, for example, we will keep all of orthopaedic surgery on the 2nd floor in the old main theatres, because obviously there's lots of kit and equipment, and it just helps to have everything all on 1 floor in that sort of size. And so really it will be, the day surgery patients will still have their day surgery in day surgery. but these two new main theatres downstairs will just be a subspeciality that's yet to be identified. But yeah, but you wouldn't split, so you wouldn't split something big like orthopedics into
No,
two floors.
that's what I was thinking. Okay, great. David?
Yeah, I think the other thing just to bring in, I mean, the ambition is that we have the whole Ashford site benefit from the GIRFT way of putting things together and the elective hub. So we wouldn't split specialties, but we would have the ethos running through the whole of Ashford. And one of the things is that, you know, for many years we've had emergency pathways ending up at Ashford. So we've had 2 wards full of emergency patients, but with the work that we were talking about earlier on, this is really a nice, a fantastically insulated elective site now. So the elective hub is these units, but the benefit is gonna be for the whole of Ashford. It's a great opportunity.
Just for the new governors, GIRFT is getting it right first time, which is the standardised way of doing it. I know that some of you would have been scratching your heads. Any other questions for Kathy while we've got her here? Just to say, I mean, this is the first major project of the provider collaborative. So it's a real test of many things, of how we will work together with our colleagues in other trusts. But it's also absolutely necessary to get waiting lists down, in particular, as you said, I think beds in Royal Surrey, David, that are very pressurised for cancer patients. So, you know, it will be a real system asset, and you know, I think, and it's very exciting. Okay, in which case you're off the hook, Kathy.
Thank you very much.
Thank you ever so much for coming and, and presenting that. I'm sure the governors, I hope you found both specialised things, actually, the ED Performance Deep Dive and the Elective Centre, helpful, useful in terms of what's coming down the line and what we're doing about various things. So thank you to James and to David on the ED Performance and to Kathy on the Elective Centre. Thank you. So we are, by a miracle, smack on time on any other business. I haven't been notified of any, but any other business for the open part of this meeting? No, in which case the date of the next meeting of this meeting is Wednesday, the 7th of June. Saying, oh, I've got Andy.
Yeah, just a quick thing. Thank you, for both those presentations. The deep dive's great. I'm just thinking, as long as it doesn't cause an increase into ED, that is a good story to share with the membership. You know, we really ought to think about that, because again, that will just help, you know, what has been the wrong BBC press, but at least we've got a story there to tell.
It's a really good point, Andy. I think we need to pick that up and tell the whole main effort story, actually, which is a very good story. Francis?
Yeah, just a very quick one. It was particularly because there are new governors. Would it be possible to have to let us know the responsibilities of the NEDs so that we can keep up to date with that?
Yeah, we're in that which committee they're on.
Yeah.
Yeah. Okay. Yeah. No problem at all. I'm sure Anu, if you could take that action, please, and we will circulate that. And there are 2 or 3 specialised ones, for example, Freedom to Speak Up, Maternity NED, etc., as well as the membership of committees. But we'll let you know that. Thank you.
Thank you.
Okay. In which case, I did the partial close before, so we'll now do the test close again in terms of the open.